This conference will now be recorded.
This training session will be an overview of the ventricular assist devices in pre-hospital management. Student objectives: defining heart failure, defining ventricular assist device and their use in treating heart failure, identifying types of ventricular assist devices, explaining the difference between pulsatile and non-pulsatile flow, identifying hemodynamic differences in patients with a ventricular assist device, list ventricular assist device related complications, demonstrate on how to assess a patient with a ventricular assist device, describe how to treat a ventricular assist device complication, identify ventricular assist device resources that can be utilized when caring for these patients. Heart failure is a condition where the heart cannot pump enough blood throughout the body. It develops over time as the pumping action of the heart grows weaker. In most cases, they involve the left side of the heart, where the left side of the heart cannot pump enough oxygen-rich blood into the rest of the body. In this case, you would see a patient with left-sided failure with acute pulmonary edema, developing fluid into the lungs. Where the right-sided failure, the heart cannot effectively pump blood into the lungs where the blood picks up oxygen, and therefore having right-sided heart failure, the patient will develop extremity edema. A single system device that is surgically attached to the left ventricle of the heart into the aorta for left ventricular support. For right ventricular support, the device is attached to the right atrium and to the pulmonary artery, and we will show you pictures later on in the presentation. Ventricular assist device is a mechanical pump that surgically attaches to one of the heart's ventricles to augment or replace native ventricular function. This can be used for the left, which would be an Lvad, the right side, which would be an Rvad, or both ventricles, which would be a bivad. Ventricular assist devices are powered by an external power source that connects to the implanted pump via a percutaneous lead called a drive line that exits the body on the right abdomen. The pump output flow can be pulsatile, where you'd feel a beat, or non-pulsatile, where it would be a continuous flow. So why do we need ventricular assist devices? Heart disease is the leading cause of death in the Western world. 5 million people in the United States have congestive heart failure. 250,000 are in the most advanced stages of congestive heart failure. 500,000 new cases each year, with 50,000 deaths each year. The only effective treatment for end-stage congestive heart failure is a heart transplant. As we know, their hearts are not readily available all the time. Therefore, they are put on a waiting list and have to have a ventricular assist device to help with them and help support the body. In 2008, there were 7,318 people that were waiting for a heart. Only 2,210 received one, with leaving 623 patients died while waiting. There's an average of 1,200 to 1,500 ventricular assist devices implanted in 2008. So let's talk about the types of ventricular assist devices, pulsatile and non-pulsatile. A pulsatile is a ventricle-like pumping sac device, where blood enters via the inflow cannula and fills a flexible pumping chamber. There's an electric motor or a pneumatic air pressure, which collapses the chamber and forces blood into a systemic circulation via the outflow cannula. Pulsatile can be Lvad, Rvad, or bivad, and the first generation devices were in early use back in the 1980s. Patients will have a palpable pulse and a measurable blood pressure. Both are generated from the VAD output flow. The The pump rate is based on how fast the ventricular assist device is pumping, filling, and emptying. This can be set at a fixed rate or can automatically adjust. The pulsatile VADs are loud, and the rate can be assessed just by listening. The output is the amount of blood ejected from the VAD, which is measured in liters per minute, and is dependent upon preload, afterload, and pump rates. So the amount of fluid going in, the amount of fluid coming out, and the rate it's coming in and out at. With non-pulsatile, these are continuous flow devices. There's an impeller, like a spinning turbine-like rotor blade, which propels blood continuously forward into a systemic circulation. The axial flow is when blood leaves the impeller blades in the same direction as it enters, think like a fan or a boat motor or propeller. Most implanted devices are LVADs only. These are quiet and cannot be heard outside of the patient's body. To assess a VAD status by auscultation over the apex of the left ventricle, the VAD should have a continuous smooth humming sound. That is the impeller spinning, continuously spinning. The patient may have a weak, irregular, or non-palpable pulse with non-pulsatile flow devices. The patient may have a narrow pulse pressure. Therefore, you would see blood pressure is very close in systolic and diastolic number. To give you an example, you would see a blood pressure of like 90/86. It may not be measurable with an automated blood pressure monitor. This is due to the continuous forward outflow from the ventricular assist device. The key would be is the mean arterial pressure is the key in monitoring hemodynamics. Ideal range is usually 65 to 90. So automated blood pressures can definitely help looking at the map. Non-pulsatile VAD key parameters. The flow is measured in liters per minute, which correlates with pump speed. So increased speed is increased flow, decreased speed is decreased flow. This is dependent on preload and afterload. The speed is how fast the impeller of the internal pump spins, which is measured in revolutions per minute, RPMs. Flow speed is set and determined by a ventricular assist device, clinical team, and usually cannot be manipulated outside of the hospital. As far as the power goes, the amount of power in the ventricular assist device consumes to continuously run at a set speed. Sudden or gradual sustained increases in the power can indicate a thrombus inside the ventricular assist device. So we're going to look at something called a PI, or a Pulsatility index, which is a measure of the pressure differential inside the internal VAD pump during the native heart's cardiac cycle. This varies by patient and indicates the volume status of the right ventricle function and the native heart contractility. The device parameters are displayed numerically on the VAD console or controller. This will vary with each individual patient in the VAD device. VAD parameters. Parameters for a pulsatile and non-pulsatile device vary with each device model, which we'll be covering shortly. Patients and their caregivers know the expectable parameter ranges and goals for their specific device. Therefore, it is very important that if a patient is unresponsive, to make sure you take family with them as long as they are trained so on the device and can give you the information that you are looking for. You need to contact the VAD coordinator at the implanting medical center. They will be your best resource when treating a ventricular assist device. Most devices are implanted over at Tufts Medical Center in Boston. However, there are other hospitals that do insert ventricular assist devices. Please make sure that you get the number from the patient or the patient's family members to be able to determine which facility you're going to be contacting. So basic VAD management. Remember that all VADs are preload dependent, so the amount of fluid coming in. They are EKG independent, and they are afterload sensitive. They will be anticoagulated, so you're going to need to look for patients that are on blood thinners. But they are also prone to infection, bleeding, thrombosis, and stroke, and mechanical malfunction. Keep in mind that there is a piece of metal inside the heart that is implanted and comes through the abdomen where there is an open terminal to get inside the body, which therefore can cause infection. The key differences depend on pulsatile and non-pulsatile devices. VADs that are commonly seen in the community. The FireTech VAD, which is a PVAD-IVAD, is a pneumatic external PVAD or an internal IVAD pulsatile pump. And you can look at the numbers that are listed here on the screen as far as flow liters per minute. These are used for a short to medium-term use up to 1 to 2 years, usually done for a bridge to recovery or a bridge to transplant. And hospital discharge is definitely possible. And you can look at the devices on the side of the screen and on the bottom, the IVAD versus PVAD for internal versus external placement. And in this photo here, you can see that these here are the external placements as they are outside the abdominal wall. The HeartMate XVE LVAS is an internally implanted electrical pulsatile pump where you have left heart support only and up to 10 liters per minute flow. These are good for medium to long-term therapy for months to years, which is a bridge to transplant. The destination therapy only FDA-approved DT devices. The HeartMate 2 LVAS, internally implanted axial flow non-pulsatile device, where you have left heart support only and runs at a speed of 8,000 to 15,000 RPM, which is about a 3 to 8 liter per minute flow. These are used for medium to long-term therapy, months to years, which have a bridge to transplant, FDA approved, and destination therapy, which is currently investigational. The Jarvik 2000 LVAD is an axial flow non-pulsatile pump. It's electric, intraventricular, left heart support only, which has speeds of 8,000 to 12,000 RPMs, which then gives you a 3 to 5 liter per minute flow. Again, you can use this for medium to long-term therapy with months to years, and as a bridge to transplant. As you can see, the implantation on the Jarvik 2000 picture on the left-hand side of the screen. It gets implanted in the left ventricle as it comes through the abdominal wall into some battery packs that keep it running. Some VAD issues. Obviously, major VAD complications would be bleeding, thrombosis, infection. Remember that sepsis is the leading cause of death in long-term VAD support. So please be familiar with sepsis indicators. Some other problems and complications: right ventricular dysfunction or failure, suck down, which is a low preload causing a non-pulsatile VAD to collapse onto the ventricle, device failure or malfunction, which is highly variable by device type, and hemolysis when the VAD destroys blood cells. Other common issues are arrhythmias. A patient can be in a lethal arrhythmia and be asymptomatic. Treat the patient, not the monitor. Do not cardiovert or defib unless the patient is unstable with an arrhythmia. Do not initiate chest compressions unless instructed by a physician or a VAD coordinator. Chest compressions can disrupt the implanted equipment, causing bleeding and death. Electrical shock and cardiovert defib will not damage any of the VAD equipment. So if you have a patient who is a VAD patient within your community and you respond there for a cardiac arrest, please make sure that you're contacting medical control prior to your arrival or upon arrival on scene before starting compressions. Other common issues would be hypertension, which would be high afterload, can limit the VAD output flow as well. We do not want to administer antihypertensive medication or nitrates unless instructed by a physician or VAD coordinator. Contact medical control. Hypotension, loss of preload, and all VADs, they are preload dependent. So a loss or reduction in preload will compromise VAD function and limit flow output. If the patient is hypovolemic, that will bring them a low preload. Other common issues are depression or adjustment disorders. Living with a VAD is difficult to manage for a lot of patients. Therefore, they may become very depressed. A large percentage of patients experience symptoms of depression. Then also have portability and ergonomics. The external VAD equipment is very heavy and cumbersome, limiting patients' mobility and greatly impacting their quality of life. Bleeding and thrombosis. Careful control of anticoagulation is imperative. Patients are often both on anticoagulants and platelet inhibitors. Device thrombosis. They're rare in the pulsatile devices and typically revealed by increased power and signs and symptoms of hemolysis. Bleeding and thrombosis transport. Treatments. Assess for signs and symptoms of bleeding. Do a neuroassessment to rule out CVA, utilizing your FAST ED and or Cincinnati stroke scale or LA stroke scale, or using an NIH stroke scale. We're going to initiate IV therapy and administer fluid slowly to maintain preload. Very similar to someone having a right-sided MI, where they're going to have preload issues. Device thrombus is treated with low-dose lytics and or increasing anticoagulation therapy. Infection is a leading cause of mortality in VAD patients. They have a higher incidence in pulsatile VADs, and the driveline provides direct access into the body and into the bloodstream, often recurrent and difficult to treat. You need to check for signs of sepsis. Patients that have signs of sepsis, obviously having a low MAP of less than 64, elevated temp, or a greater than 100.3, or if you have a patient that has a temp of less than 96.8. That would be more than what's a cold sepsis. Tachycardia of greater than 90, respiratory rate of greater than 24, a known infection site, altered mental status, and the list keeps going on and on. These would indicate patients that have severe inflammatory response syndrome, which would be SIRS, to sepsis, severe sepsis, and septic shock. Problems and complications preventing infection. Always observe clean, sterile technique when you're able to. And make sure the driveline exit site is covered with a clean, dry gauze dressing. Other problems and complications would be suck down when the left ventricle collapses due to hypovolemia or hypotension or VAD overdrive. Non-pulsatile devices only with this, and indicators would be hypotension, PVCs, ventricular tachycardia, or low VAD flows. To treat suckdown, we're going to initiate a peripheral IV and slowly give volume to increase preload. If able to and instructed by the VAD coordinator, reduce the speed of the ventricular assist device and assess for signs and symptoms of bleeding and sepsis. Device failure is a true emergency requiring immediate transport to the implanting VAD center. Now, it doesn't mean that you take your 911 ambulance and you transport to Tufts Medical Center in Boston. Bring them to the closest facility and they'll arrange for transportation. It might either be through air medical transport or by ground. Patients and caregivers are trained to identify signs and symptoms of device failure and may require the VAD to be replaced. Hemolysis is when blood cells are destroyed as they travel through the VAD. The most common are in the non-pulsatile devices with that impeller breaking up the blood. Treating hemolysis, initiate a peripheral IV and slowly give volume. If able to, and instructed by the VAD coordinator, you need to reduce the speed of the ventricular assist device. If a thrombus is suspected to be causing the hemolysis, administer lytics and anticoagulants as able or ordered to do so. All devices typically have two distinguished alarms to indicate a problem and its severity. There's an advisory alarm and a critical hazard alarm. The advisory alarm are intermittent beeping sounds that have a corresponding yellow light that illuminates on the system controller. Not critical, but the device does require attention, likely due to a low battery, cable disconnected, or a device not functioning properly. A hazardous or critical alarm are very loud, continuous trill type sound that have a corresponding red light that illuminates on the system controller. Indicates the device needs immediate attention, often because the pump has stopped or there's a problem is detected within the system controller. Most likely intervention would be required is to change out the system controller. Field management. All ventricular assist devices are dependent on adequate preload in order to maintain proper functioning. Therefore, it may require IV therapy and saline administration. Volume resuscitation is in an unstable VAD patient is the first line of therapy before vasopressors, but be cautious with the fluid, as we do not want to overload the right ventricle in left and LVADs only. Nitrates can be very detrimental, so no nitro, to a patient because of the reduction in preload. Remember that if we're vasodilating a patient, we're reducing the preload. Results in decreased pump efficiency, and consult with medical control before administering nitrates per protocol. Initiate IV therapy with all VAD patients if possible and use an aseptic technique due to the patient's increased risk for infection. VAD patients are susceptible to other injuries unrelated to the VAD. Contact the VAD coordinator. They are your most valuable resource when encountering these patients, and consult with medical control about transport. This is an emergency. Resources and protocol-driven decision making. Ventricular assist device patients require unique care that not all medical centers are equipped to handle. Transport to the implanting center when able to, or the closest VAD center. Make sure when transporting to bring all VAD-related equipment, secure the VAD batteries and controller to prevent any dropping or damage, and make sure to keep all cables tangle and kink free. If the patient is stable or unstable, we're still here in our area. We're going to transport to the closest facility, and they will arrange transport from there. As far as pre-planning goes, medical control, inquire ahead of time the level of knowledge, comfort with your medical directors regarding the management of a VAD patient. Know your transport options, air versus ground. Know your tertiary facilities and their ability to manage VAD patients. Remember, EMS can walk into just about any situation. Depending on the individuals, the family may not be able to handle the emergency. Listen to the family members. They can handle the emergency and assist them with whatever they need. The only resources and tools you can truly rely on are the ones you bring to the call. So follow up and educate yourself new technologies that enter and keep entering into the industry. With this being said, know what patients you have in your catchment area of who actually has a left ventricular or a ventricular assist device of any sort. Ask for the contact number for the managing center's VAD coordinator as soon as you arrive. This should be on the person itself or close by. This is the coordinator they work with very closely with and will be your best resource. Family, friends, and coworkers, listen to them for direction. They should be educated, trained to assist with most VAD-related complications. And 911 activation may not be for VAD-related emergency. Just because they have one does not mean that's what they are calling you for. Emergency bag containing backup VAD supplies needs to stay with the patient at all times. Should contain extra batteries and spare system controller. Ask the family for any troubleshooting guidelines that may be available. This often includes various alarms and interventions. Remember that the family and friends are not emergency responders or maybe too upset to assist you. If a VAD patient calls 911, it will be for something simple like a battery change. It will not be something simple like a battery change. VAD-related emergencies are serious life-threatening events. For additional resources or materials and information, please visit the following sites. Thank you. Once you have completed this course, please take the quiz listed below and then fill out the course roster. For any other questions, please contact your chief. Thank you.